Hi, welcome to APP virtual lectures. I'm Sara Wolfson. I'm a geriatric nurse practitioner here in Omaha, and I chose to do a lecture on low back pain, probably because in my geriatric population, the large majority of people suffer from low back pain, and it tends to be a bear in terms of trying to get people to feel better from the chronic pain they have. Oops. So back pain is really pretty common, and it's not just in, the geriatric population, of course, it's in various age groups, including kids. So you can have strain from muscle or tendon injuries, arthritis, sacroiliac problems, disc injury, which is very common from lifting too much. It does constitute a large number of visits to healthcare providers, and of course, workman's compensation, getting hurt on the job. And because of back pain, there can be lost hours of work, lost hours of productivity, and I can speak to that because I've had that issue myself. You can have mild pain, you can have severe pain, you can work through your pain and continue your activities, or you may not be able to carry on your daily activities, sitting, walking, sleeping, working. So it can cause quite a bit of disability. And one of the statistics I got is worldwide, about $200 billion is spent yearly on treatment of back pain. That's just back pain. So about 12% to 33% of persons experience back pain at any one time, and that's usually acute back pain. What we have in terms of, a real area of importance are what we call red flag physical exam findings. These are findings that signify to the clinician that there's something more acute, more concerning going on. One example would be cauda equina syndrome, which can occur affecting the lower nerves, lumbar nerves, and you could have bladder problems, inability to urinate, difficulty initiating urination. You could lose bowel control. You can have leg weakness. You can also have loss of feeling between the legs, for example, and those are things that signify to the clinician we need to do further evaluation, and very often there needs to be more prompt attention and treatment done. There's some common terminology. Sometimes it's a little confusing and whatever because there's a lot of this listhesis. So spondylosis is usually something that we find pretty commonly talked about, especially on x-rays and things, and that's basically arthritis. It looks like narrowing of the disc space, and you can also see changes in the facets, which are the little bumps that come off of the vertebral joint on either side. Then anterolisthesis is movement of one vertebrae maybe to the front on top of another vertebrae. And then you can also have retrolisthesis, which is the movement posterior, kind of a posterior displacement of a vertebral body relative to the one below it. Spondylolisthesis is a movement forward, and it can denote a movement forward from any cause. The spondylolisthesis is really not one that you see very commonly. Usually you'll see on an x-ray the anterolisthesis or the retrolisthesis. Spondylosis is a fracture in one of the little connective tissues where the vertebrae kind of go over the nerve and kind of protect the nerves. In a small percentage of people, you can get a crack in one of the vertebrae. It's usually in L5 where you'll see that. Spinal stenosis is also a commonly used term. It's very common in people. It's a narrowing of the vertebral canal. Usually you'll get arthritis and you'll get a buildup of bone. It kind of narrows the canal that the spinal cord goes through. And it can be very painful. And you usually see signs like people have a lot of difficulty standing up straight and going backwards. A lot of times, like if you go to the grocery store, you'll see people hanging over their cart and hunching because that kind of takes pressure off of that area. Radiculopathy and sciatica tend to be used sort of interchangeably. Radiculopathy is impairment of a nerve root, and it causes this radiating pain, this numbness or tingling. Sometimes there's muscle weakness, and it coincides to a specific nerve root that's getting pinched. The sciatica is the pain and numbness is more like the feeling. The radiculopathy is kind of like the diagnosis of what's going on. The sciatica is the feeling the patient has, which is the numbness and tingling. That usually goes down the back of the leg, the side of the leg. You can have it go all the way down your leg, into your ankle and your foot. Some other common terminology, I brought up the cauda equina syndrome before, and again, that's with loss of bowel and bladder control. There's numbness in the groin and areas of the perineum, and you get a lot of weakness in the extremities. A lot of times this is because there's a lot of abnormal pressure on the very bottom of the spinal cord and the spinal nerve roots, usually because of really advanced stenosis, or if there's a herniated disc that's pretty large. The other terms we have that are sometimes used, actually very often used, is kyphosis or kyphotic curves is usually a curving of the spine. You see it more in the thoracic spine, the middle of the back. And that's usually like at the level of the ribs. The lordotic curves is the inward natural curve of the spine. You want to have lordosis. That's the natural way that the spine should be held. Scoliotic curving or scoliosis is a sideways curvature. And a lot of times you'll see on an x-ray, people kind of go like this. Scoliosis will usually be a left-sided scoliosis that you'll see in the lumbar spine. And the kyphosis and the scoliosis, and if there's a lack of lordosis and a lack of that correct positioning, that puts more pressure on the back, on the vertebrae, and on the nerves, and tends to worsen pain. And you'll see also, I was going to mention, in older adults who have had the back problems for a long time, you will see a blending of stenosis, scoliosis, facet arthritis. I mean, it's just a whole mishmash of all these things that go together. So I did watch a really good lecture that the Mayo Clinic did on joints, and they did a really good one on back, and I've kind of incorporated some of the elements of that. And then I've also got the website at the very end that you can go on, and it's got like back exams, elbow exams, knee exams. I mean, the stuff, it was really good. So for the low back physical exam, the first thing is to do inspection. So watch the person walking. What does this look like? Is it antalgic? What do their feet look like? Are their feet flat? Are their knees going inward? Are their knees going outward? Some people, you can have them walk on just their toes, which goes more to evaluate the S1 nerve root to see if there's any weakness. You could also have them do heel walking, which tests the L5 root. And a lot of times what you'll pick up when you do that is you'll see foot drop. And foot drop is the L5 nerve root getting pinched. The other thing to look at is the tilting of the pelvis. Is the pelvis held straight? Is the lordosis more flattened? And if that's the case, sometimes it's because the hamstrings on the back of the leg are too tight. Really tight hip flexors will actually do the opposite, and they will accentuate and give you even too much lordosis. The core, which we usually think of as the abdominal muscles, I have to increase my core strength, is actually not just the abdominal muscles, it's the back muscles, abdominal muscles all working together because it helps stabilize the pelvis and the lower back and provide balance. So looking from behind the person, looking at the hip muscles, looking at the pelvis and the lower spine and how things are held, you want to make sure you've got pelvic stability. You want to make sure that the spine and the pelvis are held together well, that they're executing together as a team. If you have weak hip abductors, which is the muscles that help you move outward, you're going to see the pelvis tilt away from whichever side is weak. So that makes it difficult to maintain a more level posture. And a lot of times what you'll see is people will compensate for that by tilting their torso upwards. And so you'll see that if you watch from behind and you watch people walk. The next thing after you do just an inspection and just a looking is a palpation. And you can start with the paraspinal muscles, which are the two large muscles that run vertically on either side of the spine. They can go into spasm pretty easily and they will pull to one side. So if the muscles are tight, you'll see this mostly if you have people bend forward and flex the spine. That puts stress on the muscles, and you're gonna have people experience pain. If you bend them backward or you extend the spine, that stresses the posterior spine, and that will cause pain, especially if there is facet arthropathy. So a lot of times, if I'm checking people's flexion and extension and I see them bend backwards and they're going, ow, then I know without an x-ray that they've got facet arthropathy. And in a younger person, they may even have a stress fracture, and that's how you can tell if it's a stress fracture. Now, the sacroiliac joints, the SI joints, there's really not a good way to check them on a physical exam. So really just palpating and looking for tenderness. And this is actually kind of a hot spot for a lot of people, but that's the best way to tell if there's an issue with it. The legs are part of a good exam. The nerves that supply the legs come from the lumbar spine. So looking at what the legs are doing is very important. So this brings up the idea of dermatomes and myotomes, because we're talking about nerve innervation. So the dermatomes are the areas of the skin that are innervated by a particular spinal nerve. And so if you get familiar with the dermatome map, or you just kind of keep the dermatome map somewhere where you can kind of access it easily, that helps you diagnose radiculopathy in terms of which nerve is causing the problem. And I've got this little map, so to speak, on the side that can kind of tell you, for each spinal nerve, L1 through L5, and then also the sacral nerves, which area is impacted when that particular nerve is getting impinged. So for example, L5, which is very common, you're going to feel that in your buttock, the back side of the thigh, the lateral side portion of the leg. You could also feel it in the top of the foot, portion of the sole of the foot, and also in the second and third toes. So this kind of helps if you have somebody and you do an exam and you see these kinds of symptoms. That'll give you a clue as to which nerve root is the culprit. It also helps to check sensation, touching and whatever, to make sure you're checking for numbness and tingling as well, which can also occur along with these issues in the dermatomes. The myotomes are similar, except they are muscle groups that are innervated by a single nerve root. And so testing the myotomes is really important when you suspect that there's a radiculopathy. And I've got another little map here that tells you which of these nerve roots and what they're responsible for. So again, the L5 is responsible for big toe extension. So if you can have them extend their big toe and they look like they're having difficulty, that's another clue that maybe it's the L5 that's the problem root. So before, checking the nerve roots of the legs, it's really, really a good idea to ask the patient to show you where their pain is going. If it's radiating down the leg, show me with one finger, show me with your hand, what's the path that this pain is taking down your leg. That's also giving you more data as to which root, sensory nerve root, is the problem child. And it's a pretty easy thing to do. So reflexes, are also important. You want to make sure people's reflexes are normal and not hypo or hyper reflexive. And it's best to do it with them sitting on the exam table. The exam table's raised up so the feet are off the floor. And you always do both sides. Even if you suspect left over right, you want to do the right side because you want to see if there is symmetry or asymmetry, because they mean different things. So you always want to go side to side. So a reduced reflex, hyporeflexia, usually means that the radiculopathy, you're not getting it's reduced, you're not getting the full reflex effect, and that's usually one-sided. If you have a heightened reflex, you have hyperreflexia. That usually indicates that there's a spinal cord problem, which is more of a central process than a peripheral process. And that's usually bilateral. So hyporeflexia is usually one-sided, whereas hyper, too much reflex action, is usually bilateral and is more of an upper spinal cord problem. So when you test the reflexes, there's this thing called the Geriatric maneuver, which is if you don't have a really robust reflex, sometimes if you have the patient put their hands together and pull, like if you're doing a knee reflex, that will bring out the reflex a little bit better. And it enhances a reflex. It doesn't cause a hyper reflex, but it just helps the reflex to show itself more normally. So the reflexes give you needed information. Some nerve roots do have a reflex, not all of them do. And not all of them have a reflex that you can test. So you want to check the appropriate reflex as part of your physical exam. So I have an example of the L4, the knee jerk reflex, which is patellar. And then the hamstring reflex, it's a little harder to find, but it's kind of over where the knee's bent. There's kind of a little bit of a map there about where you can find it. And you tap over your finger for that one, not for the knee reflex, but you tap over your finger for the hamstring tendon to try to figure out, see how good the reflex is. One of the things that the doctor said on the Mayo Clinic thing is he believes in a really good reflex hammer. So I'm not sure what you guys are used to using. I know that what I've heard people use is the one that's got the rounded thing on it that you kind of turn on the side and hit, and you've got to really like give a good whack in order to get the right response. So for S1 and S2, because a lot of times, especially if you have an L5, that's a problem, you're going to have an S1 that's also going to be an issue. And that's the ankle jerk reflex and the gastrocnemius muscle. You also want to check for the Babinski. So that will give you an inkling that there's an upper motor neuron problem, which is, again, a spinal cord problem. And when you're doing this Babinski reflex, you want to go from the outside of the foot to the inside. So you're using from toe number 5 up the foot, and then to the left, to the big toe. And then the positive reflex is to see the toes curl forward. And in doing the reflexes, if you pair your diminished reflexes with weakness that you might see in a muscle group, that really gives you just that much more information about which nerve root is involved. And very often, if you do a really good exam, you don't even need to do an X-ray. So testing the muscles, you want to test the muscle that's just proximal, just above the next distal joint. That way you're truly testing the muscle group that you're interested in testing. So again, there's the little map on the left that has the lumbar nerves and then the muscles that are affected. So the quadriceps, you would have the patient hold the leg out straight, so they're extending their knee. You put a hand, one hand under the thigh, and then just above the anterior ankle, and you try to have the patient resist. You try to push the leg downward, and the patient is to resist. And so that corresponds to L3 and L4. The anterior tibialis is you continue to hold the leg, you have the knee extended, you have the patient move their foot backwards towards their head. That's ankle dorsiflexion. That corresponds to L4 and some of the L5. So these are areas where if they're having weakness, if they're having trouble doing it, then that's pinpointing which nerve is affected. The big toe, you move it towards your nose, that corresponds to L5. The other thing you can do is have the patient point the toes of both feet together, hold them there while you try to pull them apart, and that also helps with the posterior tibialis, which deals with inverted ankles. And you could do the same actually with the heels together, and that's the fibularis muscle group. It's a lot. I know it's a lot. Okay. In testing the hip muscles, you've got hip adductors, which with your knees bent, you got your hands between those knees, and you have the patient try to push your hands together. And that corresponds with L2 and L3. The hip abductors, put your hands to the outside of each knee, have the patient push your hands away, push their knees to the outside, that's L5. And then you have hip flexion, have the patient lift each leg with the knee bent at 90 degrees, see if they could resist you pushing the leg downward. And that corresponds with L2 and L3. And there's also an iliopsoas muscle that runs there too. And that just gives you more information. And depending upon, which age group you're dealing with, for example, in some older adults, you may have a lot of trouble doing the lifting the leg with the knee bent at 90 degrees. There's also some additional testing that you can do for a younger person, where you flip them over on their stomach. But for older people, that's not really something that's too realistic. So if you lay the patient on their back, you can do a straight leg raise. That does the lower lumbar and the S1. You lift the leg up, you try to get it to about 60 degrees. And I think what was stressed is it doesn't have to go way up, and it doesn't have to be 90 degrees, but about 60 degrees is enough to elicit radicular pain. And the S1 nerve root, which runs along more, behind the posterior thigh and calf, and the L5 runs down along the side of the thigh and the leg. To look at the hip joint, you could bring the leg to 90 degrees, and then you can externally rotate it. So you would turn that bent leg inwards, or you could do internal rotation, which is bending it outwards, and see whether or not that would elicit pain, which usually means arthritis, osteoarthritis in the hip joint. And you can check flexion of the joint with the knees bent. And then during the straight leg raise, you can ask the patient to resist as you try to press the leg down. It's more information. It just corroborates. And for a lot of this exam, it depends on how much time, of course, you have for your exam. If you're in primary care, you only have a certain number of minutes that you can spend, and you have to sometimes pick and choose what you're gonna do in terms of the exam that and corresponds with whatever the patient is telling you about and showing you with where they have their pain. Because otherwise, you'll just be in there for forever doing the back exam. So again, you can flip younger people over on their stomachs, and there's other ways that you can assess that as well. But a lot of that may not be necessary. If you really, see enough backs and enough sore backs, you kind of get to know what needs to be done and what doesn't need to be done. The scoliosis, again, it's that sideways curvature of the spine. A lot of times you can see it when the patient is standing. For a lot of older people, like my dad, who's turning 98, that you can see that scoliosis get worse over time. And you can have it in the thoracic and cervical spines as well. And generally, if you are finding arthritis in the lumbar spine, chances are good you're going to have it in the thoracic and the cervical spine, or vice versa. If you see it there first, chances are good you're going to see pain and arthritis and possibly scoliosis in the lumbar spine as well. Generally in the lumbar spine that curves to the left, we call it levoscoliosis, or a left convexity is sometimes what it'll say on the x-ray. Scoliosis does make the pain worse over time, especially if mobility is declined or people change the way that they are walking. That scoliosis will make things worse. It's, again, different from kyphosis, which is the hunched posture. You'll see that a lot in older adults, and it can sometimes confer osteoporosis. And a lot of times what that kyphosis will do is it will increase the perceived weight of the head on the thoracic spine, which could cause stress on the spine and then fractures. So imaging, it may not be necessary if you feel like you have a handle on the problem after doing the exam. And an x-ray doesn't necessarily change the treatment. Sometimes I've done x-rays for people who have maybe never had a back problem, or they're coming in, and I had a patient who was just complaining of his leg, had never had back pain, and he'd never had an x-ray, and he wanted an x-ray just for baseline. And we did the x-ray, and boy, we found out his back, he had a lot of arthritis. We also found out that he had a lumbar vertebral fracture, which he did not know he had. If there's no prior imaging, if they want a baseline condition, that's fine. Probably doing a lumbosacral, I think, is good rather than just the lumbar, so you can see what the sacral bones are doing, since a lot of times you'll get an L5 and an S1 or S2 along together. Certainly, if there's red flag symptoms like we talked about before, you want to do a CT or an MRI, and of course, insurance will determine which of the two you'll be able to order. And for a patient whose pain is not improved after 4 to 6 weeks of treatment, or if the character of the pain changes or worsens, they've been doing physical therapy for 4 to 6 weeks, they're doing patches or whatever, then doing a CT or an MRI is probably indicated, just to make sure that there isn't something that's worsening or something that maybe was missed on an exam. Physical therapy, I think, is really, really a wonderful thing. It's a mainstay. You get a good therapist who really just looks at the patient, touches the patient, and knows what's wrong. They do really good evaluations with the twisting motions and all that sort of stuff. And you can do it on an outpatient basis. For people that are homebound, you can do home health. A lot of times therapists can pinpoint, and they may come back and say to you, I think there's really something wrong here. I don't want to touch this person. I really think a CT or an MRI needs to be done. They will do core strengthening. They've got these wonderful hydroculator heat packs. They can do ultrasound. They can do electrical stim to help reduce spasms of muscles. There's something called iontophoresis, which is putting a patch over the area of the back. You inject the patch with prednisone, and that kind of seeps into the skin. And that's a series of those kinds of treatments which can help reduce inflammation without having to give a person oral prednisone, especially if they can't tolerate it or take it. Exercises you hope that people will do at home. There's always homework. They can improve range of motion, balance, and mobility. I always say to people, they may need tweaking down the road, because you'll do therapy for them. The therapy works for a while, something changes, they fall, or whatever. And down the road, they may need to have a little bit of tweaking, have the physical therapy reevaluation, and maybe change some of the exercises. And the other thing that's really good too is water therapy, because aside from the warm water, your weight is displaced when you're in a body of water like that. And a lot of times it's easier and less strain to walk in a pool than it is to walk on land. Also depends on if you've got a place where people can do aquatic therapy. Sometimes there's not a whole lot of choice. Good body mechanics and posture, it very important to keep problems from developing. And so supporting your back when you're sitting, when you're using the computer, putting things at eye level, we're all guilty of, doing this and not sitting right, and, overusing the shoulders and the neck and things like that. Don't cross your legs while you're sitting. Posture counts when you're just relaxing on the couch. Use pillows or a cushion for better support. Use the core muscles when you're standing. Try to distribute your weight to both legs. Blend your periods of sitting with standing up and stretching in order to relieve pressure on the spine, and take breaks from your desk and things like that. So for topical pain relief has really gotten to be more of a big business. And especially for older adults, who can't take like ibuprofen because they have kidney disease, or Tylenol doesn't work as well on arthritic pain, you've got moist heat. You got these really cool moist heat pads you can get at the drugstore, throw them in the microwave. They're great for muscle spasms. Just make sure, or a heating pad, just make sure people don't have them too hot so they don't get burned. It's best to like lay them down on a bed, lay down on it, and you could do it a few times a day. Again, heating pads especially, you have to be careful because a lot of times people will use them at night when they're going to bed and they leave them on and then they get a burn. We've got a lot of gels now. We've got Voltaren gel. Diclofenac gel is the generic version, and every single pharmacy has their own brand. There's Voltaren, there's Aleve gel, there's Aspercreme, and now we have all of the patches because the prescription 5% lidocaine patches insurance will no longer cover. So now there's been this proliferation of the lidocaine 4% patches, which is a strength that can be sold over the counter. So we advocate that a lot in our clinic, along with the creams and the gels, hot and cold creams, biofreeze and things. And I actually, I have talked to patients about CBD cream because I've got people who have back pain for years, and there's just sometimes seems like there's so little we can do to help their pain. And I think CBD cream is fine. You just have to explain to people that it's not regulated like prescriptions are. You're going to get different amounts depending upon which brand you get. There's a lot of places that sell CBD now, and so sometimes it's a matter of trying it. If it's not working, try a different brand because a different brand may work better. I always tell people to, if they're doing a cream, to try it on a very small area first to make sure that they don't have an allergy or an intolerance to it, rather than spreading it all over your back and finding out you have a terrible allergy to it. It's the same with the pain patches too. I tell people to try to, they can take a little piece off and put it on their skin to make sure they don't have an allergy to the adhesive. There's other aids that can help, grabber tools that can reduce the bending down and the reaching up for things. My dad's really good with this. He sits down and uses his to pick crumbs up off the floor instead of vacuuming. Support cushions are really good. They offload pressure from the spine. You have the kind where there's that you sit on. They're indentations for your thighs. And then they also have the kind that you can put behind your back in the chair. And they're portable, and they're all over Amazon, and they're really easy to get, so that you don't have to go to like a back store to get them. But I think they really do help. Soft lumbar braces, they will help remind a person, I need to watch how I'm moving. Sometimes they provide a little comfort and maybe a little confidence in the movement, because people can be very skittish with movement when you've got a back problem. And when you're skittish like that, that's going to affect how you move in general. The ergonomics, we also talked about supporting your posture. There's, better desk chairs, sitting to standing desks, having your keyboard set so your elbows are at 90 degrees, you're not slumping your shoulders. I say to some people, if your mattress is over 10 years and you're able to afford it, look at getting a new mattress. There's also some toppers that are really nice. And there's some very thin air mattresses that are priced not too badly. And again, it depends on what people can afford, that you can also use as a topper to your current mattress. And then, having them use, older adults use the walker or the cane, but making sure that they're sized properly, because if they're not, that's going to put extra strain on the back. These are my references. There's not that many. So the low back exam is on this Mayo Clinic. It's continuous professional development. It's a really good website anyway, but this came from one that talked about all the joints. Another really good one is the Stanford 25 for bedside exam skills, and just in general, not just the joints, but the, walking, your liver, murmurs, and all that kind of stuff. And then this is just a couple of things that I looked up about adult scoliosis from the Cleveland Clinic, and then facts about adult scoliosis and whatever. So, and that's it. I know it's a lot of information, whatever, but I think it's really good information. So hopefully it will help you do a good exam for your patients.